Distal femoral fractures in children are debatable because of the reason that the physis is slightly different than other physes which are present. The physis in the distal femur is more undulating and not a straight horizontal physis. That's why we can have chances of growth abnormalities more commonly as the fracture line, even which is not visible, which is not involving the epiphysis, physis, can involve the physis if we do further imaging. When distal femoral fractures happen, MUA and a K-wire is indicated. Any distal femoral fractures, when I assess the patient, if it displays, I would assess the patient, go to A&E, clinically assess the patient, history, examination, and investigations. Regarding the history, I would assess the mechanism of injury, how it happened, and what treatment was given at that time. Regarding the examination, I will assess the neurovascular status and exclude compartmental syndrome. Check the pulsations, distal pulsations as well. Splint the fracture with the position of comfort, that is 20 to 30 degree of flexion of the knee joint. I will admit the patient and plan for possible operative intervention. In some cases, I would prefer to go on for doing a CT scan if the fracture is complex. In the theater, I would reduce the fracture with on the traction table itself. This will help me to reduce the fracture easily while controlled traction is being applied. Once it is reduced, I would prefer to do a K-wire fixation. I would not prefer to have a threaded screws itself, and the K-wire would reduce the incidence of physeal injury itself. I understand that the distal femoral growth is 6 millimeter per year. Therefore, a good fixation and a good purchase is important. I would counsel the patient regarding the operative complications that consist of bleeding, infection, nerve injury, that is common penile nerve injury, compartmental syndrome, blood clots in the calf and the lung, and need for open adduction itself, and later on limb length discrepancy and angular deformities.